Hello, my name is Christy Young. I'm your advanced nurse educator for today. Ms. Smith has volunteered to be my patient for today, and we will be doing a full cardiac assessment on her. So what I will start by with this assessment is go ahead and let you know before I entered the room I did use some hand sanitizer, but also when I came in I used soap and water because that is my preference. But we have to have some kind of cleaning supplies on hand before we touch a patient. Okay, so like I've already said, Ms. Smith is the patient today. I've already explained to her about the cardiac assessment and what we will be doing. It is imperative to explain to the patient what you're going to be doing before you ever touch them and let them know each step that you're going to be doing. First of all, we will start off with some equipment. This is a stethoscope, and the large part is the diaphragm. Smaller part will be the bell. To perform a complete cardiac assessment, you would actually use both sides of the stethoscope. But for some reason in today's society, everyone seems to be in a quick hurry, so the diaphragm is the most part of the stethoscope that's used most often. So, with all of that being said and done, we will start our assessment. Okay, so like I said, I've already introduced myself to my patient, Miss Smith, and she has given me approval to go ahead with the cardiac assessment. Is that okay?
Mm-hmm.
All right. So, what I've done is got my table ready. She's on the exam table, and I have her at a 30 to 45 degree angle, and I have placed her at this angle after I have already asked her to undress down to the waistline, because as part of the cardiac assessment, we only need visual down to the waistline because we want to give patient dignity. Like I said, with that being said and done, the way I always, and I'm on the right side of the patient, so I always start with my capillary refills, and I do this by pressing on the patient's thumbnail. So with Ms. Smith being very helpful, I'm still able to do this assessment. So what I'll do is hold her finger, press down on the thumbnail, which is blanchable, and meaning that it's turning a white in appearance. And then when I release, within less than 3 seconds, it should be returned back to red, which it is, pinkish reddish tint. So after I do the capillary refills on each finger and toes for my thorough assessment, so what I would check now is clubbing. So since Ms. Smith is helping me with the video portion of this, I will show you clubbing on myself. So what you do is you place your two thumbs together, two thumbnails, and as you can see, there's a diamond appearance, and which is normal. If you do not have that diamond shape in between the nails, then that is a sign of clubbing. Okay, so now I can palpate the radial pulse using my index and middle finger to assess for rate, regularity, volume, and character. So I will check on Miss Smith. I will use the pointer and middle finger for the radial pulse, paying particular close attention to not using my own thumb, because you have your own pulse in your thumb that you can feel, which will give inaccurate information. Okay, so now, and also I forgot to mention, when you're checking the pulses, go from right to left. Make sure you're checking each side to make sure they compare. Okay, so now what I would do, since that's been done, is check for bobbing head movement. And if she was at a good 30 to 45 degree angle, I would be able to check that a little bit better. And if she does have the bobbing head movement, it's associated with aortic regurgitation. Okay, so now after that, what we're doing is checking her face for red facial appearance, which is indicative of mitral stenosis. So moving right along, since we're on the face area, what we do is we inspect the corneas. Okay. The piers, which we should never use a pier or assume in nursing. So I'm inspecting the cornea, the skin around the eyes, and also the fundus. Now what I would do as part of my assessment is ask the patient to open her mouth and stick out her tongue. Okay. And the color of the tongue should be red or pink. If there's a bluish discoloration, this is a sign of central cyanosis. All right. So the easiest part of the assessment has been completed. So now what we want to do is check for a carotid pulse, and we palpate that by gently pressing, not rubbing, with the first two fingers to assess for the volume and character of the pulse. So what we do is I would actually have her, so we can get a better view of this, I'm going to have her turn her head towards me, because typically I would check on the right side. Now you do have the carotid coming down, the external, and then you have internal carotid. So what you would want to do is use your two fingers, like I said, and gently press and not rub, and never ever palpate both pulses at the same time, because a patient can lose consciousness. So what you can do is you take the stethoscope, you can put that on the pulse, on the carotid. And all right. Now you can also measure the jugular venous pressure, and you can ask the patient, that's when they turn their head to the left while she's positioned at the 45-degree angle. Like I said earlier, I wanted to check the carotid pulse because you could see it better on the video, but to measure the jugular venous pressure, you can have her do that. So with that being said and done, what I'll do now is I'm going to listen to her apical heart rate, and you do that for a full minute because you want to note the rhythm, rate, regularity, and to do that you need to have a whole minute into that. Alright, so the preferred method, but due to video, would be you would have, like I said, have the patient undressed down to the waistline and place the stethoscope on them, and not over their clothes, underneath their shirt where you can't see where you're going. Alright, so the angle of Lewis is positioned about 5 centimeters above the center of the right atrium, and you can use a ruler to measure the distance from the angle of Lewis to the highest point at which the internal jugular vein pulsation can be seen. And then you can calculate the jugular venous pressure by adding 5. Alright, now you can inspect the patient's anterior and posterior for visible scars, and since she has undressed down to the waistline, what you want to do is you want to check all the areas for scars, and because like if they have a long mid-sternal scar, it could be from coronary artery bypass surgery or aortic valve surgery. Scars under this area, under the breast area, can be from mitral valve surgery. Okay, so now what I would do is palpate. And we're palpating the apex beat, which is also known as the maximum impulse, or as referred to short as PMI, and it's the lower left heart border. So let's just start. Let's give you some landmarks before we start doing that actually. So we have landmarks. We have the aortic landmark, which we would go down to the second, it's on the right side, the second intercostal space. Pulmonic would be left second intercostal space. The herbs would be third left intercostal space. The tricuspid would be fourth intercostal space on the left, and the mitral valve would be the fifth space, but it would be the mid-clavicular line. So look up at the clavicle, go down, and you're at the fifth intercostal space, mid-clavicular, for the mitral valve. Okay, so the PMI, fifth intercostal space in the mid-clavicular line, which is the apex of the heart, which is around the mitral valve. And that is actually where we want to listen to a heartbeat. And also, when you're palpating, if you cannot palpate, you can always ask the patient to lie on his or her side. You can also palpate for heaves and thrills. Thrill would be considered a murmur. And what you can do to check for that, the murmur, is you place the palm of my hand in each of the 4 heart zones in the precordium, and then on the upper left and right chest wall. So you can check by pressing the hands down, and that's the chest walls: aortic, pulmonic, herbs, tricuspid, mitral. Okay. If you feel a thrill, it's like a vibration underneath the hands. And then if you feel the heave, it feels like a lifting feeling. Let's see. Alright, so what we'll do is, just to sum this up, because my video is getting a little long there, let's just go over these landmarks again. We have the aortic valve area, which is the right second intercostal space. Pulmonic, which is the left second intercostal space. The herbs is the left third intercostal space. Tricuspid, fourth left intercostal space. And mitral is fifth mid-clavicular line. Never use the nipple line as a landmark, because breasts are all sizes, shapes, so you actually want to feel down for the intercostal space and go with the mid-clavicular line. And then we'll go over this right quick, like S1, 2, 3, and 4. So the S1 component is, it includes the aortic pulmonic, and it's the closure of the semilunar valves. The tricuspid valve is in the left lateral sternal border, and it closes the tricuspid valve, is the sound you hear. And then the mitral is S1, is louder than S2, which is lub-dub, and it's the closure of mitral valve. And an S3 sound is normal in children, lub-dub-dub, and it's heard after S1. Okay. So now I'm completing the assessment. There is one more thing I needed to do. I'm sorry the video's getting long. What you want to do too is check the pulses, peripheral pulses at the femoral, popliteal, anterior tibial, and dorsalis pedis pulses. And if you complete all of this assessment, it makes, and document this and let the physician know, you have accurate documentation, they can go by your assessment, and before they even put a stethoscope on the patient, or even if you do, before you do, you can have a great depth of information that you can utilize without even beginning to listen to the patient. You can base it on the assessment that you've done. And I just want to say thank you for being the patient, and thank you so much.